Hello everyone and welcome to my presentation. So today I'm actually going to present my second slide, and as I mentioned before, my subject in this class is time surveys in emergency departments, and I have made a presentation on the time study before. In my first presentation I have stated that I will go into detail and more complex studies later. So today I'm going to talk about analysis of factors influencing length of stays in the emergency departments. Length of stay is a key measure of emergency department and is also an indicator of overcrowding. Time studies that analyze emergency department processes will help us to clarify the causes of patient care delays and prolonged length of stays. And the objectives of this study is to identify and quantify the principal emergency department care time intervals and to measure the impact of important service processes such as laboratory testing, registration, and so on for patients in different triage levels. So here we can have a look of the methods, and I will go into each segment later throughout this presentation to explain it a little bit more. But briefly, how this study was done is investigators reviewed the records of 1,047 patients treated during a continuous of 7-day period in January 1999. Key data were recorded including patient characteristics, emergency process times, tests performed, consultations, and overall emergency department length of stay. Process times were determined and multiple regression analysis was performed to determine which factors were most strongly associated with prolonged length of stay. So as I mentioned, this study was taking place in 1999 on 1,047 patients, and it was done in the University of Alberta Hospital, which is actually based in Canada. And at the time of data collection, the hospital was the only center in northern Alberta that provided services for pediatric critical care, burn treatment, transplant medicine, and neurosciences. And here we can have a little bit more detail on the data that they have collected throughout this study. So as I mentioned before, here we can obtain the length of study once more. It was a total of 168 hours of study. And we can obtain the characteristics of the data that they have collected. So these are registration time, mode of arrival, initial triage level, triage assessment time, nursing assessment time, physician assessment time, medical decision time, time of departure, use of ancillary services, and use of specialty consultant services. And by the mode of arrival in here, it means that have you arrived to the emergency department by an ambulance or by yourself? So during my studies, I have actually obtained that this time intervals are almost exactly same in all of the time studies that I have analyzed, and everything else is pretty much clear. But triage is a medical term here, and so it means system of determining the priority of medical intervention in emergency rooms. These priorities are what are the patient's chances of survival based on their condition. And here we can see how the data analysis were made. So data were recorded on standard study forms, and then it was entered on Excel. Patient demographics, triage levels, time intervals, and selected variable relationships were determined using descriptive statistics. Mean time intervals were compared using unpaired two-sample t-tests. Multiple linear regression analysis was performed to determine how various patient characteristics and emergency department service processes influence length of stay. Regression analysis is actually a method used to measure the relationship between two or more variables. And if the analysis made using a single variable, this is called simple linear regression analysis. And if multiple variables are used, just like this study, it is called multiple linear regression analysis, just to make sure that everything is clear here. And so now I will mention the results of this study. So basically this table we are seeing right now is helping us to obtain how long each time interval has taken based on different triage levels. So as we can see, the triage levels, 1, 2, 3, and so on. And 5 predetermined time intervals representing the main phases of emergency department assessments and treatments were determined. And total length of stay was calculated for each patient. So here we can actually see like these are mean of these minutes. So these are actually the means. And during the 7-day study period, 1,047 patients registered in emergency department. But 113 patients were excluded because the documentation was incompleted, and 40 patients were excluded because the patients are left without being seen by a physician. And triage levels are determined here by Canadian Emergency Department Triage and Acuity Scale. And this table shows the length of stay distribution has a bell shape, and patients in triage levels 1 and 5 had the shortest length of stays, and those in level 3 had the longest. And we can also obtain by this table how each assessment varied in terms of time. For example, here we can see the physician-related interval range from 67 minutes in the first triage level and to 246 minutes, where we can obtain it in triage level 3. As I have mentioned, it took longer. And this is actually accounting for the 2/3 of entire length of stay. So here we have another table. This table is a little less complicated. This table helps us to obtain how much time patients spent in emergency departments. And as we can see here, most patients spent 2 to 5 hours in emergency departments, and 11% spent more than 9 hours, while 5% spent 12 hours, and only 0.3% spent more than 24 hours in emergency departments. Depending on their condition, the length of stay is actually varied in here. And so here's a comparison table that shows us the mean registration to nursing assessment, mean registration to physician assessment intervals, and the fractal response rates for each CTIS level. Here, CTIS emphasizes that the primary operational objective is the waiting time to see a physician. The CTAS time objectives provide useful standards for benchmarking and examination of a department's fractal response rates for registration to nursing and registration to physician assessment times. And these provided an indication of efficiency of assessing emergency department patients, actually. So in this table, it illustrates that all forms of utilization, including lab or imaging tests, specialty consultants, and admissions, increase from the lowest level, which is level 5, and the highest level 1 triage levels. And in this study, non-urgent and critically ill patients spend the shortest time in ED. As I mentioned before, it depends on their condition. Short throughput times for level 4 and 5 patients are explained by lower investigation and consultation rates. Investigation and consultation rates were similar in the top triage categories. However, longer emergency department length of stay in level 3 may reflect the fact that this patient often have very clinical presentation and require more prolonged observation, investigation, and treatment in the emergency departments. And in this table, we can basically obtain how length of stay varied for each consultation service. Consultation prolonged length of service by variable amount depending on the consultation service. Here, by consultation service, I actually mean the departments. For example, gerontology, neurology, cardiology, orthopedics, plastic surgery, and so on. And what are the limitations of this study? What affects this study? A major limitation of this study is the data gathered manually from handwritten patient charts, and that the study period was actually only limited to 1 week, and pre-including analysis of seasonal variation. And as I mentioned before, 113 patient charts were excluded from the analysis because of incomplete documentation. So it was actually a very big number, and it actually really affected the study. The implementation of better emergency department information systems will allow for more reliable and prolonged data collection to aid in decision making. And another limitation of this investigation is the failure to delineate causal relationships between predictor variables and length of stay. Emergency department processes are interdependent and subject to external influences. Therefore, improvement in one area may not shorten length of stay, and meaningful change may involve adjusting a combination of many factors. And the final concern is the generalizability of the findings are limited because of the social demographic factors, emergency department work processes, emergency department manufacturers, presence of learners, emergency service characteristics, availability of specialty consultation and inpatient service. All of these vary across sites and will be very expected to influence emergency department length of stay actually. So what are the conclusions of the study is, in conclusion, time studies provide useful data for processes in order to recognize system inefficiencies and automate them. This is actually why all of these time studies are done. And the length of stay profiles segmented by triage would be important tools for emergency management and facilitate collaborative efforts to optimize patient flows in emergency departments. Thank you so much for listening to my presentation. I'm sorry sometimes it's really hard for me to pronounce the words, so I can talk a little bit off and on and off, but thank you so much for listening.